our Western blot would pick up both HIV-1 and HIV-2, the type of assay that we have.
The Western blot does not. That's why the Western blot, Western blot is HIV-1. So what do we do? So your patient is strong positive, like the one we just saw, and I do Western blot. And I do Western blot on this one very strong. I see this. So then you start thinking, what happened to the antibody? That one, someone like this, we go check this, it go right to HIV-2. So I went over this. So this is the newly FDA cleared HIV-2. It's originally designed as a rapid test. You know, you go to Africa or something you need, but now we needed this because the country want to eventually get rid of this. So this is going to be confirmed. It's not quite out yet. FDA is working on. It's called multi-spot. You can see it's multi-spot. So it is. It look like this, but this is negative. So we did a clinical trial. I actually did a study already, and it looks like this, but hasn't been used yet. It invisibly has 4 spots. The 4 spots are what? Are recombinant. So when you have a recombinant spot, it's a lot more specific. It doesn't have a human factor, all that. So squeaky clean. One synthetic peptide is also specific. When they synthesize this, HIV-1 never cross with 2. The chemists, the smart people, they already designed. So also recombinant, that's also, it's not, see, this are natural, the virus growing in the cell. This is man-made, the virus has the sequence. So as a result, this is unique. This one's going to be a lot more specific. It will not pick up all this funny looking thing, right? So as a result, you can see this one's control. This detects as a human material. Then this is recombinant HIV-1, peptide HIV-1, and peptide HIV-2. So this one should be able to detect and differentiate your patient. So this is the one the FDA cleared, we are ready. So whenever we in doubt, we're going to put this on here. So it is a 30 minutes test. Well, from beginning to end, maybe 1 hour. I'm going to wash them, rinse them. So, and then while you add it, so this one is FDA cleared. You probably know, right? This is the oral quick. It's FDA cleared. You're going to collect the oral exudate, not spit, not like dripping. You have to go against the upper lip going, and you have to stay about 30 seconds, slowly collect. When you finish, this is not filter paper, almost like it. When this collect this, and then you actually wait for the color, wait for the bag, it will wet enough. So this by osmosis and go up. So it's really funny. I gave one to Dr. Gordon. So he was in my office way back a year ago. He told this, he said, if it's positive, I'm going to kill you. I said, okay. So he did. He was, talk, then he put it here. It's funny, for a split second, he looked a little bit concerned. Everyone does that, right?
Everyone.
Just, damn it, it better not be positive. So everything's fine. He feel really good. He said, can I have this? I said, yeah, you can have it. Take it with you. But this is so we did a study, and then actually, when we did a study, we actually used this. So they finish using this, I will collect about 20, 25 this. I also want a lot of negative. We also want some positive E. coli serum for people with bacteria. We did all that to show. Very good.
Very specific.
Yeah. So now this is, I guess, 30 CVS or something.
$30.
$30 or 50, 100 CVS throughout the country. They're encouraging people that will never can't get blood. They don't want to see a doctor. They want to do it themselves. So they're going to be home looking at the pink bag. I hope they're not drinking or on drug. Good luck. So then if anything, they have an 800 number to call. And so they'll be calm them down, tell them to go see their doctor type of thing. But this is already started. But usually at the rural places, because they think that 25% people never get tested the last 30 years. Other people, they're pretty healthy. They are in the small places, so, not close to any place. They think those are the people. So this is the new thing. This is another one called, it's called Clear View. I like this. It's, see it's open. Actually, you actually put the lancet, you do this, you just put it here. The blood come up here, you put it here, pink band will show up. So this is for people going to the visit the people IV drug center or something. Since they're so used to inject themselves, they do that, and this, but it's available, for this. But we don't want this, I say anyone come to the hospital already get the blood draw, so we really don't need this. So when we offer this, I just go find out who has the blood. Then I just gonna go right in there, for blood. This is also okay for blood, but why do I need the blood? I can do this, So our test will have a little alternative path to do the HIV. For example, the AIDS care people, when they suspect someone have them, they will let me know, and then we right now send out for HIV too, because we do this once a week. If I don't do this every day, I'm gonna lose my expertise how to put a drop or something. So we want as a reference lab, we want to be able to do this every day or eventually. So right now we send to Quest. Eventually we will be the Quest. We're working on that slowly. So here are some of the
So Dr. Yan, this is how it's reported out, or how the tech interprets. For example.
Okay. So this is today, right? So today, if you see it, you can see this. So negative control, low positive control, right? And high positive control, right? So you can and then after that I re-with them. Because they've been with me for a long time. Now here's the first patient. See, if you look at this number 17. If you see it, Tricia, it's got. I'm so used to when you see this over here. I know the person's got positive. It's got 160, 120, 65. I'm not gonna. I go right to the smudge one. There's a 55. There's a 55, 65. One is IL-2 receptor. One is reverse transcriptase. But they are not. I would joke, that's not the important band. That's not diagnostic band. It's important to be there. Then you go to smudge one, it's GP41. You come down, and this is endonuclease or something. And the people in transfusion service really you think that's important. You go to P24, and this one doesn't have that much. Usually P18 is there. But if you look on the textbook, P18 has pretty important role. It's a trans-activating factor or something. But we don't need this. This alone, this person's confirmed positive. If you draw the blood, I think I can do viral load. You draw the blood, I can do HIV DNA, and it's always there. Then if you go this person, okay, for this person EIA positive, but they sent it here for us to do Western blot. This person has nothing. So I usually, someone get panicked and call me. A couple of times I got right. I said, I see a patient 19. I say, is she pregnant? So the doctor on the other side said, how did you know? I said, experience. But see, this one has nothing. This one, once in a while, we don't know what reason. This is nitrocellular strip. Some depends on people. Somehow, for whatever reason, this person has no band, but it sort of stained the entire background. We think something patient in the blood has somehow bind with nitrocellulose, and then sort of look a brownish looking thing, but there's no band here. And if you're the last one, I don't need to know, then this person is confirmed positive. So that's what we did a long time ago. We did a 250. We just take all different category, and we got to the point where I say this, I don't even have to look the band. I know they can. And this the one, we did PCR for all this. This came out negative, this is positive each time. So after, I've been doing this since 1992, so I think I have accumulated a lot of experience. I joke, I said, I make a living reading Western blot. But see, you can see why, and you can, because whenever we're in doubt, we actually take the blood, do a PCR. We used to do that to show it's negative. And if you're ever curious, you draw a patient, actually you can order HIV DNA. In HIV DNA, HIV is an RNA virus, so where's the DNA? The RNA reverse transcribe to DNA, and then where does it go? It goes into integrated in your chromosome. It's going to be all in white blood cell. So I take the white blood cell, I find loaded, and so let's say you have a patient, you treat the patient, really behave. Every time you give me blood, not detected HIV viral load, less than 20. Give me the blood, give me whole blood, I do HIV DNA, loaded. what happens is the virus in the circulation is negative. That's good. If you so that Dr. David Ho from Aaron Diamond said, if you keep someone 30 years below detection, like 20 copy, patient may be cured. Well, who's gonna live that long anyway? So because you can keep the low, keep patient very low, the wine from the cell get reactivated, they can't fill up. They give them drug again. Wherever they have a few copies, you keep them low, keep them low. You keep just cutting. Eventually, hopefully you dry up the reservoir. This is theoretically, how can you clean the reservoir? It's like herpes. How you can do herpes? They in the trigeminal nerve, all that. You're never gonna do that. We always joke, only time they don't have is patient die, type of thing. So unless the drug can penetrate the CD4 cell, clean up, because when you see the sequence of the HIV virus, when you see the sequence, where's my pencil? Okay. I actually saw some of this, yeah. Whoops, okay. Anyway, so when you see the sequences HIV virus, actually people sequence the DNA. Thank you. So here's the CD4 cell, and then your patient viral load is negative. Give me a whole blood, EDTA, and then we break this. We actually rupture this. Here's the chromosome of your CD4, right? And then their study already show this part is HIV. They call GAG. What's GAG? That's the gene for the P24. The P24 gene is conserved, right? It doesn't expose to the drug, so you never see mutation. Drug mutation is always envelope or integrase, but integrase is the HIV virus, but the P24 is conserved. So as a result, they finding all sitting nice. They're integrated part of your chromosome. The only time you can get rid of this is you kill the cells. See, as a result, that's that will. So that's why vaccine. I mean, I don't know enough. I'm not smart. I go to all the meetings. I don't think they ever cured by vaccine. They need a drug and a vaccine. Just infuse the patient. Eventually, you get rid of all the cell that has the integrated virus. That cell has to die. The drug has to get rid of this. So how long? That's why David Ho predict. Yeah, he predict how many years. 30 plus year continued treatment with patient non-detectable viral load, and you think, geez, so-and-so is 60, he had never, So that's the sad part, but that doesn't mean never. So one day they may have a vaccine that way. So this is something that we look forward. But I go to some of your meetings. Sometimes I get a little bit sort of depressed, but depressed doesn't help, so it's good to go forward. So you can see, when you see he's the Western blot, he's loaded. So do you order the pending? And we have the blood. We do 2-3 times viral load a week. Yes. So you should get this week.
Yes, hopefully, because we have a viral load already from last week, and it's still in process.
Really?
So hopefully we get that.
So the last week, today's Monday. If you're ever curious, so there's another trick. Like patients gonna come see you. You really want this. You tell me, you get me email, and then you say you're curious. I've already been painting since last week. I mean, unless it's last Friday, today's Monday. I can go upstairs. I will find your patient's blood. What we do is we take the blood, we move to the front, so they don't have to be. Sometimes they can have a long waiting. Yeah. But if you need it really. And let me know. So we do that. I know we do for the transplant, for anyone you need. Like my patient's coming Wednesday, and today's Tuesday, or today's Monday. Can you be sure we do that? And we do that. So because it's automated. Yeah.
Wonderful.
Yeah.
Thank you.
You're welcome.
Thank you.
You're very welcome.
Thank you.